Okay. Today, we would like to welcome Dr. Jonathan Briody to the call. Dr. Briody is a health economist at the School of Population Health, RCSI, University of Medicine and Health Science, Ireland, where he is the head of health and economic impact modeling for the Center for Chronic Diseases and Population Health Research Coverage. There, he leads a team of researchers to model the impact of programs on the health and economic outcome of the chronic condition. He is also a visiting scientist with the National Public Health Agency of the United States, the Center for Disease Control and Prevention. His research has been published in international academic journals and has received awards, including a fellowship at the Health Economic Research Center and an addition to Hospital Professionals Top 100 list, which celebrates Ireland's top healthcare achievers. Currently, Dr. Briody is the PI of a large project to adapt a state-of-art US CDC diabetes microsimulation model to the Irish setting. Previously, he has conducted research on the cost-effectiveness of precision medicines in metastatic colorectal cancer and in the area of Alzheimer disease and dementia. So good afternoon, Jonathan Briody. I hope I spelled your name correctly. First of all, thank you for joining us today in the interview series organized by the IER, International Health Economics Association Early Career Research Special Interest Group. This series of interview explores different career paths in health economics to provide an overview of the variety of topics and areas where health economics is applied. So that's a wonderful career you have got. So let's start from there. Can you tell us about your research journey? How did you start your research career in health economics? And what prompted you to choose this area? And the challenges you faced by you. Over to you.
Yeah, great. And thanks for that lovely introduction. It's sometimes you forget the various things that you've been doing over the years. I suppose if we wind it back a little bit, I guess I started my journey into health economics, academically at least, by studying economics at University College Dublin. So just economics as a degree. And I completed my bachelor's and my master's degree there. And it was really during my master's, I think, that I started to develop that interest in the intersection of economics and public health. And what was interesting to me was how, economics was letting us model changes in health due to changes in things like your environment. At that time, what I really looked at was the relationship between, and this was kind of my first independent stab at being an economist, but maternal time preferences and children's cognitive outcomes. And I used a study to do that called the Growing Up in Ireland longitudinal study. And we're kind of quite fortunate during our masters to be self-directed, or at least the masters that I did, and to kind of get your first chance to kind of grab some data and do some analysis. And it was through that I got interested in longitudinal data and seeing how we could kind of model changes over time. And I guess that master's thesis got me noticed for my first kind of real research role, which was at the Irish Longitudinal Study on Aging, or TILDA, and that's at Trinity College Dublin. And it was just another opportunity where I got to see firsthand how the health of humans was being studied, and not just studied, but also assessed. Obviously, scientifically, they had a lot of, they took bloods and blood pressure and studied gait and BMI and stuff like that, but also academically. So that was where I created the first, I believe it was the first harmonized data set of Northern and Southern Irish data in older adults. And in Ireland, we kind of have somewhat of a unique population breakdown across the north and south of Ireland. So by doing that, let me compare the economic and particularly the health determinants of aging across borders. And it was just another step in that experience of applying health economic principles to data in order to answer some interesting questions. And then there was kind of a stepping stone from that role onto some work with the School of Public Health at UCD. And again, that was more, so the last role had been kind of Irish-centric. That was more of an international placement. So while I was there, I was leading out for the Irish site in a global research project. But and that was great. But the real value was just continuing to build that understanding into how economics and particularly health economics provide valuable insights into those determinants of human health and well-being. And I guess the fact that for me anyway, the fact that we could identify and model cause and effect in the real world with our research, that felt pretty amazing, in terms of, I think I just really, really was kind of blown away by the fact that we could say, okay, these things have changed and these are the predicted outcomes. And particularly when you were looking at data longitudinally and you could verify what you were doing or in big data sets, I thought that was really cool. And then just because of the work I was doing, it was in the arena of health economics. It was probably more applied microeconomics than pure health econ. But it exposed me then to that area of decision modeling and health technology assessment. And that ended up being the area that I found really interesting. Once I realized that the decisions that we were making on the provision of care were being based off of the results of things like ICERs coming out of health economic studies, it really felt like an area of research that was providing very substantial policy impacts. I was really drawn to the opportunity to do work that was able to directly improve lives by informing decisions kind of right off the bat on resource allocation and intervention strategies, very much from the angle of the research that was being done. So that's kind of what prompted me to choose this career. And you mentioned hurdles, which is, I think life is full of hurdles. Around that time, I suppose one of the biggest challenges was that when I went to do my PhD back in the day in Ireland, and I actually believe this is still the case, but there wasn't a PhD program in health economics. So there was no like, okay, PhD in this, PhD in that, PhD in health econ. So what I had to do there, or what I at least decided to do, was enroll in two programs at the same time. And that was to kind of build my own custom health economics skill set. So I completed a PhD or enrolled in a PhD program in pure economics at the School of Economics at UCD. And then at the same time, the National PhD program for Population Health and Health Services Research at RCSI. And I guess, understandably, completing the requirements for two independent programs concurrently was obviously tough. It was challenging. And they were challenging in their own ways. For the health economics PhD, the challenge was or for the pure economics PhD, the challenge was, it was very, very quantitative. So the econometrics, the macro, the micro. And that was, something that I had to scale up in. And then for the population health one, it was nearly the opposite. So that was very much I had to kind of get more familiar with more qualitative methods and understanding policy impacts and population health as a topic and stuff like that. So it was less pure regressions and various metrics and more understanding, I suppose, the application of these methods. But look, I was lucky. I was awarded the Health Research Board Sphere Scholarship to conduct my work, and that was that obviously kept the lights on and provided financial support, but also provided a lot of the other types of support that you need when you're doing this kind of work, in terms of mentors and training and kind of a platform to launch yourself from. And then, I got various scholarships and awards from UCD as well while completing their PhD programs. So there was the Geary Institute for Public Policy Research Award, which was really useful to me. And the Graduate Research and Innovation Fund Award was another thing that really helped me out. So, there's hurdles, but it swings and roundabouts. So there's been a lot of support as well. So that's probably, I'm probably rambling now, but that's probably the best summary of my early research journey, I would say.
So that was great to hear. It's a long journey you had. So coming to the next question I'd like to ask you is that your research interest is in modeling the cost effectiveness of intervention in chronic diseases. Can you tell us how you choose this particular field in health economics? In your view, how significant is such modeling in the prevention control of such diseases?
Yeah, so I think an interest in chronic disease really leads on from the last question. It's nearly like the next step in the journey. I think because my background, as I described, was across quite a number of health spaces, I started to see chronic disease as kind of representing not just, a significant economic challenge, which obviously it is, but also a major public health challenge. And I definitely saw an opportunity there to contribute to addressing this challenge that we all globally are and will experience through kind of evidence-based modeling and analysis. So, I've had some grants on cancer and on diabetes and Alzheimer's disease and dementia. And I remember a colleague of mine saying to me, like, why are you applying for such really disparate areas of research? And in my response was that, all of these diseases are in some way or another a type of chronic disease. And my thought process in each of these grants was that these were areas that, where we were seeing the condition as a chronic disease is only growing. So if you think about it, we have these amazing treatments improving and extending lifespans, which obviously, is great, thank God. A lot of these diseases end up being pushed into the chronic disease space subsequently. And that's an improvement for human health. But I suppose that's when we really need health economics as a tool in order to help us improve healthcare systems. So basically, if we can improve healthcare systems, then the knock-on effect and the intended knock-on effect or consequence of that is that we're improving patient outcomes, and ultimately we're improving population health as a whole. So I guess then, leading on from that, particularly because what I do is predominantly decision modeling, so health technology assessment and considering the cost effectiveness of intervention, the question that becomes really important is, okay, we're extending lifespans for people with chronic disease. So they're living longer and hopefully they're living well with these conditions. Or maybe in general, our population is just living longer in general. So we're having a longer population lifespan. But the individuals who are having health needs are now going to be experiencing health needs that are going to be more complex than they were in the past. And the consequence of that greater complexity is a greater degree of cost. And so what this comes back to is that core kind of age-old problem that everyone experiences, apart from maybe some of the billionaires out there. But resources are finite. And if we're investing a lot of money into, this new amazing oncology care, then as a government looking after our people, we're taking from a pot of resources that we're available to invest in, say, neonatal units or vice versa. We only have so much pie that we can share around. So when I took that more aggregate view of health as something that isn't just disease specific, and I think it required studying these different areas of health to understand that, and to realize that, so not just focusing on better health for people with Alzheimer's disease or better health for people with diabetes or cancer or dementia or whatever it may be, but it's something that's produced by a government to be netted across all its people. That's when I started to see that, look, if we really want to be improving health and moving the needle on improving, the well-being of everybody, then that means being very disease non-specific. And particularly what that means is trying to figure out how to best divide up our public funds in a way that makes everybody better off and nobody worse off. So there's such a thing as a Pareto efficiency, right? So we should be at a point in the funds that we make available to people where, or to healthcare provision, where it's not possible to move our money around even by a cent without making people worse off. That's how optimized we have it. And I think health economics really gets to the heart of that.
This chronic disease is one of the important area in health economics. So your research is apparently involves public policy engagement. What is your experience with the policymakers? How far inputs from academic research shape public policy, especially in Ireland, public policy in health?
Yeah, so policy engagement is critical. And I think in health economics more so than any other area of research, apart from maybe obviously like clinical trials and cancer or some of the more kind of applied medical stuff, I think we're really lucky to be, working in a discipline where our work is directly influencing public policy. So we're in a situation where we can produce research to demonstrate that when a healthcare intervention is provided to a population or a subgroup of the population or individuals experiencing a certain condition, that it can improve health by, say, X amount, and it will either cost Y amount. So, look, cost a certain amount, or it might be cost effective, or so it falls below the threshold of what we consider to be good value for money when we're providing care, or it might even be cost saving, which is, I think, every health economist's favorite result. And that's because in the latter particularly, you can really demonstrate to policymakers, look, if you provide this care, it's going to save you money, and at the same time as saving you money, it's going to be improving health. And that's something where I've gone, one-on-one, and I've met with agencies, healthcare agencies, and they've really sat up and listened to the results of some of the work we've been doing, because they can see those real world implications. You can say to them, here's a new intervention and it works so well, or it decreases toxicity so significantly that if you were to give this, your costs of healthcare are going to decline, because you're going to have less people presenting to the emergency room or having some awful comorbidity, or requiring second line therapy, which is quite costly. People's health and quality of life will improve. They'll live longer. They'll have a better quality of life. So in terms of what we're currently doing, it's kind of a no-brainer to provide this. So I think that's really useful. And then that kind of colors that the jump from research to policy is just that little bit shorter, I think, with decision modeling and health economics than with a lot of other areas of research. When I studied the effects of maternal time preferences and children's cognition, or during my PhD, local area unemployment and health, these were areas that you could make policy recommendations, but the impact was maybe a little bit murkier. Health economics, it's a bit clearer, and I think because of that, you have to be a bit more mindful of policy from the get-go. If you can skill up and you can start to understand this area a little bit better, I think that's something you're really going to benefit from as a health economist. Previously I worked as a policy analyst for the Irish Fiscal Policy Research Centre, and that was an independent think tank. And when I was there, what I really wanted to do was learn that new language that I didn't have from an academic background. So, I knew that I could do research, but then the question that I had was, well, do I know how to translate that research to others? And at times, I think the ability to be able to translate good research to individuals who are in the best position to receive and to act on that research is probably, it's at least as valuable as doing the research itself. So if you were to do, the world's greatest study ever, and it was perfect and it was airtight, and you really identified this relationship that no one's seen before, and the way that people could act on that relationship and improve things or change things for the better, if nobody knows about that and nobody listens to you, then you're gonna struggle to make kind of a real tangible difference with your work. So we're doing the work not to just kind of show statistically significant relationships or show cost-effective ICERs, but we're doing it to improve population health and well-being. So yeah, when I was with that policy think tank, I got pretty deep into some of the kind of larger, more significant policy events that were kind of key in health economics at that time in Ireland, as you said. Things like the Health Act was big back in the day, the framework for the pharmaceutical reimbursement environment. And a part of that was producing policy documents, of course, to provide to our government in Ireland. But another big part of it was scaling up again in how to do things like infographics and kinetic topography videos and research videos, and even little research cartoons and things like that. And the reason for learning how to do that and kind of implementing those things was to kind of capture people's attention. Being able to present data engagingly enough to bridge that gap between academic research and the public. That the goal being to enhance engagement in research that's ultimately being done for the public. And that engagement is something that I try to continue even now, all these years later. Here in Ireland, I was very, very honored to be appointed to the National Screening Advisory Committee by our Minister for Health, which is our individual who makes a lot of decisions on the provision of healthcare or supports that. process in Ireland. And in this role, what I'm trying to do is bring that independent advice in evaluating population-based screening programs from a health economic perspective. And as you said, this is where I really have seen firsthand how inputs from academic research, purely academic research or scientific research, can be shaping public policy and can be leading to significant population health benefits. We've seen suggestions that were made being implemented and adopted, and we've seen improvements in population health as a result of those. So that's been pretty significant.
So that's very significant. I see that after COVID, there is lots of public policy on health all over the world, which is a very important step towards a good health system in the global scenario. So coming to, so your most recent research activities include estimation of long-term health and economic impact of diabetes and cost-effectiveness approach for the control and management of this condition. For this, you have used a microsimulation model, if I am correct.
You are, yep.
Can you tell us more about this model?
Yeah, definitely. So I'm conscious probably that some of your viewers might not be so familiar with microsimulation. And microsimulation is it's basically a type of model designed to estimate the long-term health outcomes and cost effectiveness of interventions for managing a disease. So very similar to market models or whatever. But it's interested in the disease. I would probably describe it as over its natural history. So what it's doing is it's tracking individual level data. So things like populations or an individual's risk factors, their clinical outcomes, whatever, over the lifetime of a population that represents a disease. So what I've been doing in RCSI is adapting a state-of-the-art simulation tool that was developed by the CDC, as you mentioned earlier, in the United States to the Irish setting. So it's obviously come from a US cohort. It's kind of like a national model, and adapting it to Ireland has been quite an interesting process. I partnered up with various different. So predominantly, I'm adapting it in the area of diabetes, and I've been partnering up with some studies on individuals with diabetes here in Ireland. So the Midlands study, I've had some conversations with diabetes in general practice and Mitchelstown cohort study, all these different various studies of the disease in the community. And I've actually also gone and organized some of my own prospective data collection where we've gone into Irish hospitals, we've sought some funding and some really good medical students and collected hospital-based data as well. And what we've done is we've aggregated this data and combined it in order to integrate Irish-specific data on things like demographics and healthcare costs and disease history, and progression rates and health-related quality of life and things like that into the model. And in that way, kind of more accurately describe the Irish picture of diabetes nationally. And because of how we've adapted this model, it lets me simulate, I suppose, various treatment scenarios and then estimate their cost effectiveness at a population level and over that population's lifetime for the disease in the Irish setting. And it's what's interesting there. It's not it's kind of like an engine and fuel. So the model is the engine and the population is the fuel. And once you have really good fuel, you can kind of drive your engine anywhere. So now that we have a really good population and adaptation of this model to the Irish setting, and we can look at more or less any intervention in pre-diabetes, type 2 diabetes, type 1 diabetes, and I suppose I'd like to expand that out to other conditions that I've worked on in the past. And I suppose what makes this model kind of unique in microsimulation as a kind of a modeling strategy unique is its ability to capture that complexity and heterogeneity of disease that I described at the start. So it's looking at an individual level rather than an aggregate level. So I'm sure you're familiar that typically in health economics we can work in things like Markov models and stuff, and they're very useful tools, but sometimes they miss out on that those kind of like specific characteristics of a disease. You know, you get a kind of a big picture, which is useful, but if there's little quirks in disease populations or cohorts, those can be missed. So applying a microsimulation to kind of sufficiently detailed data on demographics and risk factors and the history of a disease captures a lot more of that data, and it really brings our lifetime projections of population outcomes a lot closer to what we actually see in the data. And it allows us then, once we're confident that we're really projecting quite accurately, we can study the cost effectiveness of basically any proposed intervention without actually having to apply them, because we're using these risk equations, which are just mathematical modeling techniques, to project outcomes that are super representative of the real world patient experience. And that produces then an unprecedented level of information for policymakers on the potential benefits and I guess the trade-offs of various healthcare strategies. So what I've been doing, I guess, in that context, now that I've built up that modeling infrastructure, has been to apply that microsimulation to evaluate the cost effectiveness of different strategies for, you know, preventing disease, for screening for disease, for managing disease, and including things like lifestyle interventions and medication, and maybe earlier or even more complex disease identification programs, not just for the disease itself, which is obviously important, but in the chronic disease space, it's also really important to be looking at the complications of the condition. So there's been a lot of work, as I said, in the area of diabetes. We're hoping to maybe expand that to some of the other chronic conditions, so many. And that's what our center is for, and the part that I lead. And I suppose, you know, at the same time, I've been helping that amazingly talented team that I work with here in Converge to apply the model in their own research to kind of multiply the effect that we can have here, and we can bring other people on board and support them applying it, and really trying to have a multiplicative impact in the kind of research that we're doing.
Yeah, that's a very fantastic model you are using. Lots of econometrics concepts you are using. So my next question is basically for most of the listeners of this interview are early career researcher. As a research supervisor, what advice and tips can you offer to them, to our early career researchers who are listening to this interview?
Yeah, I think that's a really good question. There's a lot that could be suggested. I think something that might sound kind of strange, but one thing that can be a great asset in health economics, and I'm sure in many other disciplines, is the ability to work. So to clarify that, you know, if I'm going to be realistic, sometimes people call economics, you know, the dismal science. And health economics is definitely a science with a mix of medicine and maths and programming and theory and journalism all thrown in. And there are definitely going to be a lot of occasions where you have absolutely no idea what's going on. You don't know what you don't know. And the only thing that you can really do in that scenario is kind of plant yourself in a seat in front of a screen and really concentrate on getting to work on figuring out what you need to figure out. So I think that ability to kind of steel yourself and say, no one else is going to figure this out, you know, I have to figure it out. I think that's something that's, you know, maybe health economists just need to have a really thick skin and take a lot of punishment. I'm not sure, but I mean, by the same token, I'm not saying that you have to do it all on your own. I would say that if you can build up a strong team of collaborators to work with, that's something that's going to pay dividends in being able to pick up on things a lot sooner. So, you know, my advice, particularly when you're early in your career, is that it makes a lot of sense to see if you can co-author on some of your kind of more early stage projects with someone who's a lot more senior, and they might be able to provide then more of an advisory role. So they're not going to you know, if you pick the right person, they might not get stuck in coding up a model for you, but they might be more able to answer your question when you get stuck, or help you with code review, or understanding the logic behind what you're doing, or things like that. And sometimes, you know, I think you can get a more intuitive explanation, and you can kind of understand and maintain that understanding from someone that you interact with in real life. You know, you can go back to them and you can ask them more questions, and you can kind of get them to contextualize it specifically in the project that you're doing with them, or in terms that you understand. And I think that can be a lot more straightforward than just trying to look into a textbook. So maybe the advice there is recognizing that it is a challenging area to work in, that it's broad, that there's a mix of expertise that you're going to need to have, and maybe collaborating with individuals who kind of round off those areas of expertise that you don't have. You know, on top of that, I would recommend this is a frank one, but I would recommend looking for mentorship opportunities that are outside of where you work. So I think we all have a tendency, unfortunately, to not to want to look kind of stupid in front of the people we work with every day. Nobody wants to look stupid in general. So that makes it quite tempting not to ask questions when you're not sure about something, because you kind of feel, or you might feel, you know, well, will people think I don't know what I'm doing? Will I think I'm not very good at my job? Will I think, oh God, we should really fire this guy? And obviously that's not the case. People aren't thinking that, but imposter syndrome, you know, it's a real thing. It is a problem that everyone deals with, no matter how senior they are. And so in those cases, having a mentor outside of your school, that might just give you enough of a buffer to feel comfortable in saying to someone, look, I don't get this, you know, I don't understand this. Can you explain it to me? And when they say to you, you know, they explain it to you and you don't understand, then you feel comfortable saying, look, I still don't get this, like, I'm sorry, but, you know, and I think that can be really useful. You know, it can be academia and the world at large is a competitive environment. And that can sometimes kind of make people feel like they shouldn't step up and say, I don't get it. But if you look at the people who are really succeeding and doing well, these are the people who don't mind looking silly in a moment. So in the long run, they can know what they're doing. And that kind of, you know, advice of looking for, you know, health economists outside of your institution, you know, it folds into that, you know, another kind of reality that there aren't that many health economists around. So, you know, if you have viewers watching this and they're saying to themselves, well, I'm the only health economist that I know, or I'm the only health economist in my department, that's not an uncommon experience. That was my experience for a number of years. And what I found was really helpful, and I think what can help others is actively engaging with that research community online. So, you know, it's nice in health economics. And I think this is why we have that big divide and kind of like those memes in health economics of like, do we use Excel or do we use R for modeling HCA and stuff like that? And, you know, do we use Stata? Do we use R? And various jokes like that. People like to feel part of something. They like to feel part of a gang or a group or whatever it may be. And health economics is quite good for that. It might be because of ISPOR or IKEA or DART or the Society for Medical Decision Making or other groups like that. But when you engage with these groups and you follow them online and through social media and you engage with their members, you can see that there's quite a tight-knit community in health economics. And if you can keep up with them and be friendly with them, I think it's critical to not feeling isolated, because when you're isolated about something, it's just going to make things seem a lot harder than they actually may be. Whereas if you have a team and you're all kind of on the same side and you're all fighting the good fight together, it's a lot more motivating to say, okay, well, I'm struggling, but so are they, or I'm doing this, but so are they. I'm a health economist, and so are they. You know, I think that's actually, yeah, really useful.
Yeah, same. Yeah, yeah, same for me also. I'm the. You can hear me?
I can hear you, Gopal. Can you hear me?
Yeah, same for me also, because I'm the only person in my university, in my department, doing research in health economics.
So it's not uncommon.
So you,
You're not the only one.
uh, So you have mentioned about R programming language towards the analysis of cost effectiveness of health intervention. Can you tell us about this? Can you suggest some good resources, including basic study materials for our young researchers in R and R software and all?
Yeah, of course. So my first role, post PhD, I should say, was studying the cost effectiveness of precision medicine in metastatic colorectal cancer. And that was something I got to work on with this amazing project called the Colossus Project. And I'd never used R before. My background was mostly in things like Stata, like I said, for regression analysis. But I knew this would be something where I needed to either use Excel or R to do that kind of modeling. Stata really wasn't going to be a good fit for that. And particularly, I've always felt very strongly that when you're building a model, you should really open source this where you can. At the very minimum, it helps validate your work. So when someone else comes along after you and looks at what you've done and what you've reported, if you've open source what you've done, they should be able to replicate what you've done, and that adds a lot of reassurance to the conclusions that you're making. So if you're making policy suggestions and they're based on your research, you want to be able to reassure people, okay, well, look, if you came and did it after me, you'd get the same results. So these results are a characteristic of the data and of the real world rather than the manner in which I've kind of approached the data. But in addition to that, and equally importantly, I think that if you spend a lot of time building something that's useful, then hopefully by making it available to others, someone else might be able to come along and they might be able to leverage your model in their own research. So they could study the same thing, or they could use your model to build something bigger on top of what you've started. And ultimately, you would hope that that would advance population health. So you all make little increments of improvement until you reach the last person who's kind of saving the world. And that's what we want to do as health economists in the end, right? We want to be, advancing population health. So, I suppose that's a long way of saying, in that respect, R seemed like a natural choice. It's free and it's open source. So it meant I could use it as an open source piece of software and an open source project, and I wouldn't have to worry about copyright issues. And it plugs very easily into GitHub. And that's where I wanted to keep my model so that anyone come along and just load up my webpage and download my model and carte blanche to do whatever they liked with it. So that was my strategy. The only issue here was that I hadn't used R or GitHub or anything like that before. And I didn't really know anyone who had, and that was pretty daunting. So the approach that I took went to Google and looked at applications of R in health economics that were similar to my own use case. So I knew it was a three-state Markov model looking at metastatic disease, and there was some survival analysis and various other things that were done, probabilistic sensitivity analysis, etc. And that helped looking at those tutorials. But what actually was the key thing there was that as I read these tutorials online, I kept seeing the same references, I should say, being made, and they were always to the same kind of handful of groups. So back when I was doing this, and I'd say this has only gone from strength to strength, but it was the Center for Health Economics at the University of New York, the International Society for Pharmacoeconomics and Outcomes Research, the Society for Medical Decision Making, and then the Darth Work Group. So I took all the training that they provided, that was relevant to what I was doing. And, I was in a fortunate position where I was in a grant that had a training budget that would cover this. Because it could have gotten quite costly, to be honest. But there's a scale also of the cost in these training opportunities. Some are pretty affordable, even if you're footing the bill yourself. So some of the lower middle income country specific materials, I think some of them were $20 for a 2-day course, which I suppose depending on your financial situation, but in comparison to lots of the other training that was available, that seemed quite reasonable. And then the other thing that I did, and which is something that you can do for free, is I joined some communities. So the R for Health Technology Assessment Group, who are interested, as you might imagine, in supporting people to provide R for Health Technology Assessment. There's also R for HTA in lower and middle income countries. I think that's useful as well because the perspective there is very much to the LMICs that are making up that group. And then there's another, numbers of other groups, and they all have a lot of free resources available on their web pages. Even the Darth work group, which I is probably my favorite of all the work groups. They publish papers all the time that are open source with open source code and model applications and tutorials. So, you can get to grips without having to spend all that money. And then what I did to kind of add to this, and I often find that if you can learn interactively, that's a really useful thing to have. So something that I did, which may not be fully scalable, is that I tried to reach out to and to get to know these groups as best as I could during the training that they provided, but also afterwards. So, if I'd learned something with the Society for Medical Decision Making or DART or ISFOR or York, and then I went and applied it in my own work, I would reach out and I would say, remember that cool thing that you taught us how to do? I've made a kind of what I think is an interesting application of that in my own modeling. And what do you think about that? And, you have to remember that a lot of the time, the people who are providing this training, they're providing it because they're passionate and they care about, health economics and R for HTA and open source modeling. So combining that with my own kind of keen interest in all this, there were a number of occasions where that opened the door for a really deep dive on a lot of the work I was doing. And subsequently, I suppose I was invited by some of these groups to come on and actually teach for them. And that was a really good way to learn as well. So as you're preparing for something like giving a lesson, you're really getting to know the material and to understand the ins and outs of it much deeper, I suppose, than when you're just kind of passively receiving it, and even if you're actively receiving it, because you know that you want to know what you're talking about when you go and pitch it, and you want to be able to answer questions and things like that. So I think those were my steps in kind of scaling up.
Yes, I also remember my first struggle with R, because in India at that time, nobody knew what is R software means. And I did a course in edX with MIT, and the teachers were Esther Duflo and Abhijit Banerjee, the Nobel laureates. So they gave us so many workloads for R, and it was a very struggle at first, but I really enjoyed that software. So coming to one of the last questions for you, how do you envisage the future evolution of health economics as an academic discipline? What are the emerging areas? What will be its role in public policy making, health economics?
Yeah, so I think you've kind of nailed hit the nail on the head there with policy making. I see health economics becoming increasingly interdisciplinary. So I think it's already interdisciplinary, but I think it's going to be more and more important that we get to know our neighbors in the clinical setting. So at the end of the day, if we're studying a new intervention in health, the reality is that, okay, we're academics and we're quite informed, but we're only going to know a small fraction of what our medical partners know. So building strong relationships in this area from the get-go is something that's going to be critical. And not just for insights on your work and studying, say, a particular medication or a particular disease space. It's also really important in terms of uptake and buy-in. You're never going to get a better champion of your findings than a clinician who believes that what you're studying could improve the well-being of their own patients. So, kind of taking that on board to describe some of the more scientific findings that I was getting in health economics to a more, I would say, a broader kind of non-specialist audience of health professionals, I have found something that's really useful is to author kind of bespoke articles on the research that you're doing for clinical publications. So some of those have been, some of the work that I've done was obviously featured on the cover of these magazines, and as you mentioned at the start of our chat, that led to me making the hospital profession top 100 list. And what the upshot of all of that was that it really helped my research have an impact across disciplines. And it introduced me to quite a broad spectrum of medical professionals, because just like there's not one type of economist or one type of health economist, there's not one type of doctor, right? And because I have that relationship now across these groups, I can directly engage with people on a lot of critical issues emerging in the economics of healthcare. And these are people who have an interest in what I do, and feeding back on that, and also in sharing that interest, and sharing that research and the findings that we have with their colleagues. So I think critical is what's going to be so critical, especially is clinical relationships, and capitalizing on those. In terms of the rest of my crystal ball, I think one of the biggest emerging areas is going to be the need for the economic evaluation of precision medicine. And ultimately, what we're seeing is that as we move towards more complex and more costly care, obviously the cost of that is going up. And in some cases, that's unavoidable. So if you consider CAR T-cell therapy as a relatively novel therapy in hematology and blood cancers, that is something that it's challenging to see how. So in Ireland, our ICER threshold is about 45,000. CAR T-cell therapy is such an intensive, complex means of care that it's challenging to see how it's going to be cost effective to provide that based on that kind of an ICER, based on conventional thresholds. But by the same token, it's a care that you're providing to individuals who have who traditionally have limited care lines available to them. So these are individuals who it would not be unusual for them to unfortunately to die at this stage of their care, and we're seeing CAR T is giving them instead remissions and at times permanent remissions. So it may be a situation going forward, the future of health economics, and we might have to revisit what we think is an appropriate value to deem something as being cost effective. And within the community, so that's maybe more a policy answer. With the community itself of health economists, and I hate to use the panacea of artificial intelligence because I'm sure it's brought up in every conversation now, but as it's becoming more and more commonly used, I won't speak to its quality or its application in modeling, but what I will say is that I can imagine that it might nudge more health economists into using something that is a programming language like R over Excel, because R is something that's, because it's open source, is a lot easier to make integration with AI than something like a spreadsheet software like Excel is.
So finally, what your advice to the whole aspiring health economics researchers?
Yeah, that's a good question. Advice. I think this is maybe the best piece of advice that ties kind of our entire conversation together. Actually comes from one of my hobbies. So in my free time, I like to make video games. So not like a big, I don't know what, Skyrim or something like that, but just kind of small little things, nothing crazy, just for fun. And there's an expression in indie game development, which is if you want to make a game, you should just go and make a game. And I think it's kind of the same here. If you want to be a health economist, you need to just start a health economic project, ideally today. And commit to a study, go and build a health economic model in R, and start writing a paper. And that's because that's really the best way to learn something. It's just by going and doing it. It's probably the same with most things in life. And as you're working through the different parts of what you'll actually have to do to actually complete a health economic analysis, you'll really start to understand what it means to be a health economist and how exactly you can be one. And when you're doing that, so as I said, jump in, dive in, but also when you're doing that, try and remember how long the journey can be. So there's no denying that even, a single paper can take you years to complete. And I think what you need to do then is to remember to celebrate the small wins as you make progress and to enjoy what you're doing as you do it. I've always felt really lucky with the type of work that I get to do, even on really kind of challenging days. And tough days, because it's such an interesting and interdisciplinary field to work in, I still love what I do and I really enjoy it. And I think it's something that you probably find yourself once you get started as an aspiring health economist that that it's unlike a lot of the other disciplines that are out there.
That was a beautiful talk. Beautiful advices you have given to our young health economists, researchers, and early career researchers who are listening to this, listening to your talk. So, yeah. So I like to thank you for that wonderful things you have said, and also I uh, like to tell you, hope to see you at the Bali IEA Congress in July. And
Excellent.
I also hope to see the listeners to the IEA Congress in July at Bali. Thank you.
Thank you very much, Gopal. I appreciate it. And if anyone wants to reach out to me in terms of any of this, just feel free. I can probably Google me, and I'm up there on Twitter. I don't tweet a lot, but or even you can email me, which is just my first name, my surname at rcsi.ie. If anything, if you're just starting out and you want some tips or tricks, feel free.
Thank you, Jonathan. And I hope that I'm sure that they will send you emails about Korea. It was
Thank
nice
you.
talking to you.
It was lovely to talk to you, Gopal. Thanks again.
Okay. I hope the interview went well because there is connection instability here. It was going out and coming.
No problem. I think it went smoothly, and we can always revisit anything that you want to revisit anytime. So that's
Okay.
great.
Thank you, Jonathan.
Thanks
Thank you
again,
for
Gopal.
joining.
Good day.
Thank you.
Bye.
Bye.